welcome Vishali GUPTA, who's going to talk about minimal imaging criteria for the non-infectious posterior uveitis.
Thank you, Jen. Thank you, Mark. Thank you, AIOS and all the members for this beautiful project. So can I have my slides, please? Perfect. So we heard the previous two talks. Jen beautifully told what sun has done for uveitis. It standardized the nomenclature, but it did not standardize the imaging language, and we are in the era of multimodal imaging. So what we decided was to standardize the imaging language, and to begin with, we just chose 5 diseases. Okay. Non-infectious posterior uveitis, we chose these 5 diseases because they have been clumped together as white dot syndromes. And like Sapna said, they were dumped together because we did not want to differentiate one from the other for the sake of convenience. But they are not the same. Some of them need treatment, some do not need treatment. So we decided to get away with the term of white dot syndrome and to identify each one of them separately and put them as non-infectious posterior uveitis. And the studies which we studied included mutes, serpiginous, birdshot, AMPI, and multifocal choroiditis. So I shall be talking about minimal imaging set. And for those of you wondering what is minimal imaging set, it's the kind of that everybody doesn't need every lab. Similarly, every patient of uveitis does not need everything in imaging or multimodal imaging. Sapna showed beautifully that for multifocal choroiditis, probably all we need is a color photo, OCT for activity, and autofluorescence to look for near lesions. You do not need everything for everybody. So we wanted to define it, what experts think would be the minimal imaging set for these entities. It was a complicated process, and I'm not going to talk about how we did it because Sapna has explained beautifully, and this is how we decided. So we had committees. Each committee was given a task, 2 tasks. One is to generate the clinical utility statements. For example, what is the role of ICG in multifocal choroiditis? Does it have a role? And if the role, what is the clinical utility? And the second was to give us minimal imaging set. Each of these entities, what is the minimal imaging criteria the experts feel should be done? So I'm going to talk about minimal imaging set for these 5 entities one by one. All these reports have been submitted for publication, and I'm very thankful to all our contributors who have spent a lot of time in showing what I'm doing today. So let's begin with serpiginous choroiditis, something we see very commonly out here. So the first question, when you see a patient and the color photo or the clinical exam is equivalent. So you look at the image and you ask yourself, well, it looks like a serpiginous choroiditis, and you are quite confident, well, this is serpiginous choroiditis, yes. You do not need any multimodal image to tell you whether it is serpiginous or not. Clinical examination and color photo are enough. Well, you say yes, it is serpiginous choroiditis. The next question you ask yourself, is it active or inactive? To determine the activity, the minimal imaging required is autofluorescence and OCT, not fluorescein, not ICG. So, and both of these are non-invasive, and this is something majority of the comprehensive ophthalmologists have it these days. In the autofluorescence, you look at the edges. The edges are hyperautofluorescent. It means the disease is active. If everything is dark, it's inactive. You look at the OCT through the active lesion, which shows hyperfluorescence in the outer retina, again indicative of the active lesion. This is the autofluorescence of inactive, which is totally dark, and this is during the follow-up. You can see these hyperreflectivity in the outer retina is gone, and what you have is a kind of the scar. This is inactive. So you do not need any invasive investigation. During the follow-up, sometimes in the scar there can be development of choroidal neovascular membrane, and if you want to see that, it is angio-OCT at that particular time. The other is you look at this clinical picture and you're not sure whether it is serpiginous, is it AMPI, is it something else. That is the time you would do fluorescein and ICG, because you want to differentiate serpiginous from AMPI or other things, not for anything else. So this was the minimal imaging criteria regarding serpiginous. And then we come on to the next entity which Sapna has already described, and I will show you in one slide, multifocal choroiditis and PIC. They both have been clubbed together because it's believed they are spectrum of the same disease. So you look at the color photo, you can make the diagnosis. You do not need imaging. So color photo and clinical exam is enough. You want to know whether the disease is active or not. You do OCT through the lesion. You see the shrum which is fluffy, the disease is active. You can do autofluorescence, hyperautofluorescent lesion, the disease is active. Well, you are monitoring. If you are monitoring for reactivation, autofluorescence is a good modality to show hyperautofluorescent new lesions or sometimes late phase ICGA. But if you are monitoring for choroidal neovascular membrane, it's angio-OCT. Now, what is the role of fluorescein and ICG? Virtually to show you the extent of the disease, nothing more than that. Coming to the third, this which we talked about was about MUDES. What are the minimal imaging criteria? And we are now seeing quite a few number of patients with MUDES, especially in the post-COVID era. I don't know why. The first question when you look at the color photo, you ask, is it MUDES? Do the autofluorescence, because autofluorescence is one which will show the characteristic feature and you will come to know, well, this is MUDES. OCT, again, you can do, and in OCT, the sparing of the choriocapillaries and choroid actually favors the diagnosis of MUDES. Now you have looked at the color photo and autofluorescence and you are quite confident that this looks like MUDES. Well, it is typical for MUDES. Nothing more is required to make the diagnosis. And if you want to monitor the resolution, you can do the autofluorescence. All these granular white appearance, they will just disappear because MUDES is one-time event. So you don't have choroidal neovasculars appearing or you don't have to monitor. It's one-time event, it will disappear. You can just do color photo and autofluorescence. The second thing is you're not very sure it's MUDE, not very typical. And there is something called epi-MUDES, which is a secondary MUDES and other confusing thing. Then you do the fluorescein, ICG and OCTA to differentiate it from other entities. Coming to AMPI, and there has been a lot of overlap between AMPI and serpiginous because AMPI might begin as AMPI and get into serpiginous. We are not talking about the transition, we are talking at presentation. So if you look at the color fundus photo for morphology, you can say it's AMPI, but not with that much confidence as you will say multifocal or MUDES. So you need fluorescein even to make the diagnosis of AMPI. The spots which are hypo and which become hyper. You need ICGA and OCTA to make the diagnosis of AMPI because the areas of choriocapillary non-perfusion are a requisite for making the diagnosis of AMPI. So you will need these investigations right in the beginning. Then comes whether this AMPI is active or not. Of course, you can do it on fluorescein, hypo to hyper, but this is very typically OCT through the lesion, which shows activity in the outer retina and then resolution. And last is birdshot. Birdshot was a different thing altogether. Color fundus is enough, but you required ICGA to differentiate whether it is acute or chronic, whether it is active or inactive, and even for monitoring the birdshot, ICG and fluorescein were required, whereas none of other white dots required ICG to monitor response to therapy. So these were the 5 minimal imaging sets which were given by our committees, but we did not just want them to be released like this. We wanted to validate it in the real life, that if I present it to you, will these stand the test of the time in simple words. So what we did is we had about, during the live meeting in Singapore, we presented mix and match of these criteria in a very methodological way, and we asked people to vote for the minimal imaging criteria. We had 156 ophthalmologists who participated, and our main outcome measure was that, well, we are proposing, but what is the sensitivity, specificity, and accuracy of these criteria compared to color fundus picture alone in diagnosing, assessing activity, and identifying the complications. So this is nutshell kind of my last slide, which shows that if you want to make the diagnostic purposes, minimal imaging set actually outperformed in mutes, AMPI, and birdshot. This was very valid. If you want to look at the activity, minimal imaging set allowed participants to achieve better results in all non-infectious except AMPI. And identification of complications was tested in serpiginous, multifocal, and PIC only because mutes doesn't have these complications, and minimal imaging set outperformed. In simple words, like if you are looking for CNV, you can't diagnose it on a color photo, you need OCT, angio, that kind of outperformed. So most interestingly, the minimal imaging set was very helpful in simple, straightforward cases. But in cases which were complicated or which are atypical or where you are not sure about the diagnosis, you may need MMI, multimodal imaging, you may need ICG, you may need everything. But if the case is straightforward, you don't have to do everything for everybody. For making the diagnosis, for accessing the disease activity, or for looking at the complications. So this was the validation exercise which confirmed the utility of most of the proposed MIS, and they increased the ability of ophthalmologists to diagnose and manage most cases of white dots, which are now non-infectious posterior uveitis, and this has nothing to do with the physician's background and clinical setting. We at IOSG are very, very mindful of the discrepancies we have in the world and the access to the imaging technology available. So we found that there was no difference. You could be sitting in the top-notch university or a dispensary somewhere in Sub-Sahara. These criteria we found were comparable in both the settings. A complete MMI approach is needed for more challenging phenotypes, and the moral of the story is that you don't have to feel discouraged that since you can't do everything, you can't diagnose. You still can diagnose in majority of the cases. Thank you very much for your patient hearing.